can't really see all the faces, but I know there are some familiar faces here, and some of whom have been working with me, even before I first ever went to Liberia, which was during the Civil War in 1991, which is why I think when WHO put out a call for help, they put out several calls, but one came in July, and a couple of us put our names down, Jim and I, and because I had briefly been in Liberia during the Civil War, they posted me to Monrovia. And our brief there was to support the response, the Ebola response, and to give support to WHO and the Ministry of Health. And in fact, there were so many different things that needed to be done that it was actually very difficult to get very much done. But I'll go through some of the challenges and some of the journey in that. So the primary objective of us was to provide technical assistance for the implementation of different components. So David has gone through some of them with you, the top of which is coordination, but also case finding, contact tracing, infection prevention and control, safe burials, community response, social mobilisation, psychosocial support, laboratory. So all the key elements of an outbreak response. I was based in the city of Monrovia, which is similar to Dublin, population 1.6 million. Liberia itself is quite similar to our country in that the population is around 4 million, but the health indicators are very much worse than many countries, with life expectancy of less than 60 years and an infant mortality of 71. And you'll see there the maternal mortality is extremely high, 770. So there are many challenges in Liberia before Ebola ever hit the country, and the same for all the neighbouring countries. And you can see it wedged in there between Sierra Leone and Cote d'Ivoire. And this is when we arrived. They just had 2 treatment facilities, which is a core part of Ebola response, which is the isolate and treat the patient. And you can see that there's just 2 orange spots there. One was in Lofa County, which was very close to where the outbreak first entered the country, in a rural area. And what happened in Liberia is the outbreak quickly spread to the urban area, and it spread when people thought that they had it under control. And in June, they realised that the cases had spread from March in the countryside right into the city of Monrovia. And that was a toxic mix, because the city of Monrovia is, like many African cities, got a huge slum population and many challenges in water and sanitation. When I got there on the 20th of August, as I arrived into Monrovia from the airport, I could hear a colleague speaking on the radio, and from there until I left 3.5 weeks later, you were imbued with this sense that Ebola is real, Ebola is everywhere, and together we can stop the spread. And this was one of the most important slides, because it really emphasised to people, it's not about stigma. This is not a makey-uppy story. This is not the government trying to distract you from what's going on in the economy, which were some of the rumours. And the lead in case management of the country is Dr. Moses Massacoy, who used to work with me in MSF in Malawi. So I felt that, gosh, there's a big movement here. And sure enough, there was a big movement, but there were so many challenges that I have to say that most of the time we were feeling very frustrated and a big sense of despair. But things move on. So this was the main source of information that people acted on. This is the dispatcher, the triage, and you can see it here. If you have this, if you have that, yes, no. And this was like the Bible, and that defined us whether we were probable suspect or alert case. And that's how the system responded. At a free phone 4455, you rang the free phone, and of course they had to be verified. Many of them were crank calls, but most of them were about real issues. My job in the city of Monrovia was to try support the case investigation and the epidemiological and surveillance, which is acting on the cases. And this is what we did. We go out to people's houses. We wouldn't go inside. We take the history. This family had serial deaths from the middle of August, 8th of August, until the early September. Every week a different member of the family died. But there's no great panic. We're talking 3 metres apart. I'm there at the side. And, the biggest problem with what we were doing is there were no treatment units. There were no beds. As soon as the treatment unit opened, filled. So this is the treatment unit in John F. Kennedy Memorial Hospital, which was an old cholera ward. We were trying to help them support the information because you really needed to know what happened to the patients. We had to fill out the case investigation form. And that was a big challenge with record keeping. And it still is a challenge because Ebola has been inflicted on a country that has already got very weak health systems and very weak monitoring systems. So what a huge amount of effort went in with the support of WHO and other partners, CDC, especially in collating data, but MSF were a key partner in terms of actually treating the patients. So the burial was a very important. When I first got there, I said, why are we spending so much time on burials? We're doing more for the dead than we are for the living. But it made absolute sense because we removed the infected, deceased patient from the household, which was the most important thing. Some patients were in the houses for 10 days before this. And burial meant cremation. That was a huge effort in Liberia. The Liberians had to come to terms with cremation, which was only used by a minority of the Muslim population. So this is a brief overview of the EPI as of the last week of September, when I was joined by a colleague from Dublin who was working with EPI, the European Centres for Disease Control, and she's a microbiological scientist. So you can see that the curve has gone up and up and up, and it appears to be going down. That's not quite the full story because there's a 2-week delay in data, but funnily enough, that has been sustained. The numbers have gone down. Before we get to that, this is Monserrado, the city of Monrovia, which is, I used to think, very similar to how I operate here. City of Dublin, the eastern region, nobody gives us enough time, attention and resources in the HSE. The same debate went on in Liberia because it was a national response, and then the Monserrado, which is a county, we felt didn't get enough attention. And so we're constantly chasing that. But they have the highest number. You can see it's an amazing number, followed by Mugibi, which is the neighbouring county, and then Lofa, which was the one in the rural area. You see, you're talking about big numbers here, but you really need to look at rates when you look at Ebola, and you can see that the densest rates, over 30 per 10,000, is around the city. Okay, so that really was what the data showed us. The rest you probably know. Fever was one of the strongest symptoms, which is very important. Fatigue, bleeding comes at the end. Healthcare, it affects everybody in the population, farmers to traditional healers to healthcare workers mostly nurses, which is very sad, and all grades of healthcare workers. And this is just to show you some of the pictures when we first got there. This is a mobile lab. This is the Statistics Institute, which was very difficult to get good data, but they were very keen. This is JFK Hospital, which is empty at the time and is still, I think, barely functional. Did open while I was there. And this is the treatment centre in JFK, which is very basic. It's the old cholera ward, but they've built huge numbers since. This is the way you go in, dipping your foot into the green basin water. This is Orla Nadine, very young scientist. Behind you see the buckets, which are the bread and butter of the response, buckets and spigots with chlorine water. And this is the Ministry of Health. There was trucks coming up with donations every day. This is a typical patient dying on the street, and some people didn't feel they could help them. Some were homeless, some were pregnancy related. This is interviewing outside the house. All the neighbourhood come. This is the politician who buys his own ambulance, delivers the patients, skips the queue, gets votes. This is our training, our team. This is a storeroom, and this is the mobile lab again. This is MSF as they're expanding. MSF had a huge response. I have to say they were heroic. This is a market in Monrovia, so it doesn't even begin to show you the density of population, the huge numbers. And this is what I saw when I was there, so concerned we're out there, and this is very important because at the end of the day, this outbreak will be won or lost with the community. So the community has been an incredible part of the relative success. In the last 2 weeks, the cases have dropped. There are now beds and treatment units in Monrovia. They've set up several new treatment centres, and there are lessons to be learned. But I think there is a little glimmer of light of hope that the fragile health system that's there, with the support of partners in the NGO side, the ministry side and international partners, And a lot of that relative success is probably due to some of the awareness raising and other initiatives.